in the end, valve, you should understand why each valve opens and each valve closes by the time we're done here, before the test day, right? They all open because of pressure. Valves open when pressure ahead of them is greater than pressure behind them, right? In other words, in the forward direction, high pressure to low pressure opens the valve. The opposite, if blood's trying to flow backwards, in other words, if the pressure in front of the valve is high and the pressure behind the valve is low, well, okay, behind and in front is getting confusing. Let me restructure. Valves open when the pressure on the we'll do downstream and upstream. How's that? So when the downstream pressure is high and the upstream pressure is low, then blood is trying to flow backwards. That closes the valve, right? Okay, let's just look at the picture. Left atrial line, blue. These are all pressure, so pressure, time. Left atrial pressure, red is left ventricular pressure, black is aortic pressure. Okay, so atrial contraction, that's the little tiny blue line, right? We get a little bump and then it goes back. Another little bump goes back. All right, look at this section right here, the red versus blue. So you can see that very quickly after left atrial contraction, as soon as the ventricle starts to contract, the red line crosses the blue line. In other words, the pressure in the ventricle becomes greater than the pressure in the atrium. That pushes the valve closed. Okay? So left AV valve closes because ventricular pressure exceeds atrial pressure. Right? Now we get isovolumetric contraction. So heart's contracting, but nothing's moving. Now, once the pressure in the ventricle exceeds the pressure in the aorta, that pushes that valve open, right? So the aortic valve opens when ventricular pressure exceeds aortic pressure. Then we get ejection, right, up here. The aortic valve will close when the pressure in the ventricle falls below the pressure in the aorta, because at that point, blood will try to flow backwards. It'll fill up the little cups on the aortic valve and it'll slam it shut. All right, then the heart will continue to relax until the pressure in the ventricle drops below the pressure in the atrium, and then at that point the left AV valve opens and we get filling happening again until we get way over here and we get another contraction. Okay? So the ups and downs, the valve opens, valve closes according to when the ventricular pressure relative to the aorta or the atrium changes, right? So go through that a couple of times on your own, and I think that you will see what I'm getting at here. So when the red line crosses the blue line, that's AV valve closes. When the red line crosses the black line, that's open. Red line crosses the black line again, that's closed. Red line crosses the blue line again, that's open. Right? And then we have our different points. So isovolumetric contraction, isovolumetric relaxation, right? Semilunar valves, that's what we call both aortic and pulmonic. Okay, they get a common name. Now, what you're seeing here is left side of the heart, left atrium, left ventricle. Now, the nice thing is you don't have to learn a separate pattern for the right side. It's the very same pattern. The only difference is the pressures are much smaller. Okay? But the valves open and close due to the same reasons and at the same time. So in a normal, healthy patient, the left and right valves open and close at the same time. The aortic and pulmonic valves open and close at the same time. So when we listen to the heart and we hear the lub, we're actually hearing two valves close at once. And then when we hear the dup, that's two valves closing at once. All right, so as you learn to really listen to the heart next semester, there are some tricks you can do to listen to each valve separately, right? So one of the tricks is you have the patient take a big breath and hold it, and that tends to split the first heart sound, so you can hear the difference between the left side and the right side, the left AV and the right AV valve. All right. So it's all about pressure. That's what's making the valves open and close. It's also what's moving blood around. Yes, sir.
Why does ventricular pressure also increase when some diastole right at the beginning at 1 and 2? So when the atrium is filling with blood, why does the ventricular pressure also from like 0
Where are we at?
0 to 100 milliseconds?
Here, down here. Okay. Oh, why does this go up here? You're seeing the increase in pressure from the atrium transduced into the ventricle because the valve's open. Right? So when it's that little bump, this little bump is what we're talking about, folks, is when the atria contract, they generate a small amount of pressure. We can measure that in the ventricle. So see the bump here and the bump here line up. So it's from the same cause, left atrial contraction. Yeah. Other questions? All right. All right. So add some details, which sometimes I've already talked about these, but there's a lot going on here. Okay. So the ECG changes precede the volume and pressure change, right? So like we talked about the P wave. P wave, atrial depolarization leads to atrial contraction. You can see the depolarization happens first, then the contraction follows. Has to be like that. You have to depolarize before you contract, right? QRS, the interval is much smaller, but still you can see we are depolarizing. We have movement in electricity before we have contraction happening, right? So across the board, the ECG changes precede the physical changes, right? So electrical first, then physical. Excitation before contraction. Heart sounds are made by valves closing, right? So both left and right AV valves, both pulmonic and aortic valves close. We talked about isovolumetric contraction and relaxation. You should be able to describe those and what they're for, right? Pressurizing the heart and then depressurizing the heart. Ejection, that's this part. Heart doing the work that the body needs it to do. I think the easiest way to see ejection is not up here, it's down here, right? Because here you see the volume of the ventricle drops very quickly. Where did it go? Well, it got pushed into the aorta, right? So we got some forward motion. Filling, this is the filling time, all right? So there's passive filling and then active filling. Passive filling, there's no heart making this curve happen. What's happening is blood is trickling back to the heart and draining into the ventricle. So the volume is slowly increasing. You can see that during this filling, the pressure doesn't hardly change at all. Okay? And it's because in diastole, the ventricle has a very low pressure. That pressure doesn't get high until we get into systole, right? So low pressure filling, then we have a bit of active filling as the atria contract, and then we go into contraction again. Atrial versus aortic pressure. You can see a huge difference, right? The smallest pressure that we see in the aorta is 80 millimeters of mercury. The largest pressure we see in the atria is like 5 or 10 even in pathology. So you've got this huge difference. And that is why we need the isovolumetric contraction and relaxation. It's like a pressure lock, so that the pressure from the aorta doesn't end up in the atria, because it would literally push the blood backwards, right? So we can't have that. Okay, there are two points where we considered volume as kind of marker points: end diastolic volume and end systolic volume. I will often call these EDV and ESV. Okay, so end diastolic, end systolic. End diastolic volume, like its name implies, at the very end of heart relaxation, the ventricle is as full as it's going to be, right? So here is EDV, right here. At the end of diastole, just before we start ventricular systole, that's our highest point on the volume curve, right? So that's EDV, heart most full. ESV is heart most empty, and we get that at the end of systole, right? So at the end of ejection, when the heart has gotten as small as it's going to get, then that is ESV. We take the combination, the difference between these two, heart most full, heart most empty, and we give it a name. That's stroke volume. That's how much blood did the heart eject in one beat, okay? Because and then if you take that, so stroke volume is volume per beat. If you multiply that by heart rate, beats per minute, then you get volume per minute, which is cardiac output, okay? Our primary measure of cardiac function. Do you have a question?
What about ejection fraction? When do we measure the EF on somebody?
Ejection fraction is not represented in this picture, okay? Ejection fraction is looking at the same thing, okay? EDV to ESV, how much does the heart shrink in size, okay? Ejection fraction, is, for those of you who don't know, is something we measure on echocardiograms, right? So when you're watching the heart move, this is a little simplified because it goes, if you look at the bottom of the volume graph, it's not 0, right? It's 50. The ventricle never gets to 0. There's always some blood that remains, right? So when we talk about ejection fraction, we're talking about the amount of blood left in the heart at the end of systole versus the amount of blood in the heart at the beginning of systole, right? So it's looking at the same thing, but it's a little different measure. It is, you can literally take ejection fraction and make it stroke volume. You just have to know the volume of the heart to do that. All right, a lot of important clinical stuff in this, right? So to just touch on like, well, why does this matter, okay? One of the things that happens in heart failure is that the difference between EDV and ESV gets smaller and smaller. In other words, if you've had a big, massive heart attack, your heart doesn't empty very well, right? So the heart is full, in fact, it's full and floppy. But when it contracts, it's like, so it just doesn't push very much. Your ejection fraction, your stroke volume is very low. So essentially the body isn't pushing blood forward very well, and then you're going to have perfusion issues, right? So these measures are actually clinically used.